Very honored and thrilled to introduce Dr. Leslie Shaw. Leslie, welcome. Let me introduce Leslie, and let me also position myself. When I was a young researcher back in India, and I was doing a project on dobutamine stress echocardiography, and I was amazed at the time by the volume of the work that she was doing in cardiac imaging. And I was very intrigued because at the time, looking into cost efficacy and some other aspects of very complex analysis, I think she was a name to go to refer her work to. Least did I know that at one day later on, 20 years, I would be able to not only be meet her, but also be able to work with her in JACC imaging. So Leslie, it's been a great honor and privilege. She's one of the most a distinguished, well-regarded researcher in a space that spans starting from outcome research, cardiovascular imaging, sex differences, racial, ethnic differences, preventive cardiology to women's health. She's world's leading authority specifically in specific focus on sex differences, and she's currently an endowed chair and tenured professor with appointments in cardiology, OBGYN, reproductive science, and population health. She's the director of Blavatnik Family Women's Health Research Institute and vice chair of research in Raquel and Jamie Jelinski Department of OBGYN and Reproductive Science at Icahn School of Medicine at Mount Sinai. And she leads the Women's Health Initiative all across the Mount Sinai Health System. In her work, she has distinguished herself with over 1,000 publications, being qualified as top 1% researcher in all across the spheres with an H index of over 154. She's the executive editor of JACC Imaging, and she has been awarded numerous awards. A few to name are Salmon Dak Awards for Academic Excellence in American College of Cardiology in 2013. She was also given the Coalition of to Reduce Disparities in Cardiovascular Disease Outcomes Award for her research contributions in racial and ethnic differences in CV sciences. She also received the Women's Day Red Dress Award for her scientific contribution to women health. In 2020, she was awarded the Bernadine Helly Leadership in Women's Cardiovascular Disease Award by the ACC, and also received the Nanette Wagner's MD Award for American Society of Preventive Cardiology. She's one of the rare individuals who has served as president of two medical societies of cardiovascular medicine, being ASNC and SCCT. And with that, I'm really thrilled to welcome her. Today, her tilt is going to be talking about cardiovascular imaging and what it can do for cardiovascular epidemic across the globe. With that, Leslie, the floor is yours. Thank you so much for joining us.
Thank you so much, Partho. It's I've tried to do this talk a couple of times, and I'm really excited that we could now get this going here today. And I'm going to briefly talk about some of the background that I think a lot of you may have been hearing. I guess if we could start off just thinking about what you all do every day, and here's a list of my disclosures, including I do a couple talks a year for HeartFlow. What we all do every day, how much all of you have contributed, and the global burden of cardiovascular disease is just not going away. And as a matter of fact, it's really it's headed in the wrong direction. It's really incredible when you think about how much the burden of disease has grown and how diversely it is growing across the world. And if you look even more detailed, and I had the privilege of participating in this Lancet Commission, and if you were
You are muted, Leslie.
I saw that. Can you guys hear me now?
Yeah.
Okay, awesome. So this just came out a few weeks ago. It was simultaneously published at the ACC, and I'm going to be highlighting some thoughts. And this is a new concept of thinking about coronary artery disease as we move forward into dealing and tackling the issues around coronary disease. Sorry, it doesn't seem to be advancing. There we go. Okay, so if you look, and this is just giving you where we are today in 2025, and looking just over the near term, there's going to be tremendous growth and the mortality associated with coronary disease. And that is true in Europe, North America, more so in other developing countries, particularly Latin America and Africa, as well as the Middle East and North Africa. But certainly it is also contributing to high rises in coronary disease mortality in the United States. This is where we are in terms of our diagnostic approaches. This is from the recent chest pain guideline. As you can see, a lot of the focus of testing is in the higher risk patient populations. So even if you are not really an imager focusing on dealing with whether it be echocardiography, CT, or MR, which is largely a lot of the areas that I work in, I want you to get the concept and the idea. We are focusing on the highest of the highest risk group, the larger population of asymptomatics and low risk, as you all know, often have subclinical atherosclerosis. And really our approach has been not to test that patient population. I want you to hold that thought for a minute. And then if you look at our current approach for guiding primary prevention, it's based upon utility of some form of a risk factor-based risk score to guide primary prevention. Well, one of the big challenges is these scores, whatever it would be. In this case, this is the pooled cohort equation. In the next slides, it could be the new preventive risk calculator, which does improve a little bit by adding BMI, GFR, hemoglobin A1C, urinary albumin to creatinine ratios, getting some kidney and more metabolic factors in there. It does allow for you to include the zip code of the patient, which could capture some ideas of social deprivation. The challenge is these risk scores, when they calculate, they certainly give you an idea of the patient's risk, but they really work very well on populations and make it hard to be very precise in terms of guiding risk on any given patient. And as you look, and you all know this, every clinic that you attend, as you look at your patients, what you see is a lot of risk enhancing features or other factors which are going to drive risk in that specific patient, which isn't noted in all of these risk factor calculations. So again, there's reasons for us to have pause in how we approach cardiovascular disease, particularly ischemic heart disease, coronary disease. The risk factors, our current guideline approaches don't seem to be enough for a large share of patients. Nearly 40% of patients, and this has happened throughout my career, we've seen this, a large percentage of patients presenting with ACS were often deemed at low risk. And that's true. And if you particularly very few younger age patients are deemed likely to be eligible for statin therapies. And this is even these findings are even more prominent. And I've listed 4 studies here, but all of you can think of your head another 10, 15 studies that show that we aren't quite there yet in terms of really capturing this idea. And then if you start to look across ages, our risk factor burden in our young adults, to me, it's rather shocking. 1 in 8 individuals under the age of 50 are hypertensive, and these rates are even higher in African Americans, upwards of 1 in 3, depending on the study. And I'm going to talk about obesity, but 40% of the US population is obese. 5% are diabetic, but these numbers just increase dramatically after the age of 45, where the rate of diabetes just skyrockets to almost 1 in 5 patients. We know that subclinical atherosclerosis, so the disease process has started in many of the patients who walk into your clinic and are sitting in your waiting rooms. Upwards of 60, 70, even 50% of women are there and have subclinical atherosclerosis. So they've started the disease process. It is not a process that goes away. It's a process by which will only progressively worsen. And really, when we look at our risk factor burden, the cumulative duration of exposure to risk factors. That is a prominent predictor of progression of disease, as well as it heightens event risk. So, and here's just a slide that we did from the CAC consortium. You can see in that middle of this slide, somewhere in the 50, 60, 65-year-old range, a ton of your patients in this group will have evidence of atherosclerotic plaque, even simple evidence like just having any detectable plaque on coronary calcium. But let's look at the United States in the year 2050. You can look at the rising prevalence of the percent of patients who have cardiovascular disease or the number of patients across the ages. But if you look at the lower right, you'll see very, very prominently that from the time we are right now until 2050, roughly 2/3 of the American population will be obese or hypertensive. That's incredible. We're not headed in a good direction. And you can see that likewise an increase in the prevalence of diabetes. Again, we have to really stop and have to make some drastic changes in order for us to catch up to this. Certainly we are not going to be able to handle this. So we have to start rethinking, how can we reshape what we're doing today? And the blue line actually in that lower right is declining prevalence of dyslipidemia. So, you know, I think in the last 4 years, I had the honor to work on this Lancet Commission. And the Lancet Commission commissioners asked us to see about writing a statement on eradicating atherosclerosis. And when I first was on my way to this meeting, I thought, that's ridiculous. But when I really started to think about it, I started to think about how our focus of ischemia, is it really the best way for us to think about things? You know, maybe we should focus on the underlying plaque burden and shouldn't wait for the patient to be symptomatic or to have unstable angina. And so another way for us to think about it is our traditional approach, and maybe visualized on this slide, where the goal of all forms of diagnostic testing is really the detection of an significant obstructive stenosis, whether it be 50% or 70%. Yet for the most people, for the other groups that are on this slide, you do see plaque in these center 3 slides here, where you can see these figures. All of these patients have non-obstructive plaque, but yet our focus is not necessarily to tailor towards them. So, you know, should we really start rethinking and put a threshold for saying a patient has coronary disease when they actually start to develop plaque? So automatically, when you say that patient has coronary disease, your automatic thought is they have significant stenosis. But what if we just identified this as atherosclerotic coronary artery disease and focused on anybody that had atherosclerotic plaque, whether it be non-obstructive or obstructive, and focus on intensification of preventive strategies across an array of clinical risk subsets with the different types of disease? So really, our traditional approaches, when I started to think about this, I started to think that we were diagnosing atherosclerosis way too late in this disease process. And can we really reshift our focus to detecting a continuum of disease stages, either early non-obstructive disease or late obstructive disease, all along that continuum, and really allow for a lot of graded treatment strategies targeting plaque that's amenable to regression or averting of an ACS heart failure or whatever that term is. And you can really use this paradigm in a lot of different areas, not just atherosclerosis or coronary artery disease, but also in other areas. And of course, we need research. I don't want you to, by any stretch of the imagination, think that we're ready for this paradigm. The reason we all have to start talking about it, because we're all going to need to jump in and figure out how to do this. Trials like the Scott Heart, which you can see on the right-hand side, is a treatment trial in patients with atherosclerosis that are asymptomatic. And we hopefully see this trial in the next year or year and a half. So how do we do this? I mean, the focus is on delaying, halting, or reversing the disease, if possible. The evidence is by no means available and ready for use, but it certainly tantalizes us that we can start to think about changing the disease process and probably not getting rid of it, not that I can see, at least with our available medical armamentarium, but we can start to think about delaying disease or even halting the disease process. CT is just one of those that I think shows promise in detecting atherosclerosis and can be used in large populations, whether they be asymptomatic or symptomatic. And we really start thinking about this whole idea of imaging guided prevention. So the echo folks listening to this don't really think about this as CT, really start to embrace the concept of using imaging as integral to guiding care of a patient. We got a little hint of this with the Scott Hart trial, which in the secondary analysis of it, showing a longer term follow-up, they did show a decrease, about a 40% decrease in coronary disease death or myocardial infarction in patients who receive CT. The protocol recommended preventive care, aspirin and statins, in patients that had non-obstructive and obstructive disease. It's hypothesized. Now remember, this was not a randomized treatment trial, so we can't really jump off the rails and try to say this is evidence. But certainly it's interesting, supportive data that when we actually link CT findings of plaque to much more intensive management across an array of time, we can perhaps elicit an improvement in outcome. And of course, most of you are familiar with this. We now currently have CT abilities to quantify plaque. Now you can see these figures. I could spend the whole time talking about the limitations of that. I just want you to keep this in mind. This is still a work in progress. Even though it's being applied clinically, I still think we have to be really cautious about the AI-based automated image segmentation and the subclassification of varying types of plaque, including calcified and non-calcified plaque. And we certainly, here's just a case. We have enough data that has been aggregated. We're capable of finding out how much plaque a patient has. In this case, a 54-year-old woman who's hypertensive. She had a negative stress echo, but yet had a fair amount of plaque at a pretty young age. She had over 600 cubic millimeters of plaque, mostly in her LAD. So we're able now to get an idea of how much plaque a patient has and what is that in relation to somebody of their given age. So the data is slowly aggregating. This can be very helpful in understanding the patient's plaque burden. But ultimately, what we'd like to say is, can we identify this process of going from a very stable patient in order to predicting which one of these culprit lesions will actually progress? We know from decades of research, the vast majority of culprit lesions were previously non-obstructive. We've seen that, well into the late 80s, 1980s, and well into our current era. And the whole idea is then, if we can identify those at high risk of progression, is that we can initiate stabilization and perhaps avert that ACS. That's the general idea behind this. And we have seen, a number of papers, which I'm going to highlight on the next few slides. So this concept, though, of intervention of early stage atherosclerosis, non-obstructive plaque with or without a stenosis, we do have the potential to avert progression to ACS, some form of ischemic cardiomyopathy, most importantly, sudden cardiac death, and particularly coronary revascularization. That whole concept, it sounds beautiful. It sounds perfect. It sounds why all of us had a passion for cardiovascular medicine. What we don't know, and which is I want you to have caveats to this, we don't know is if we change plaque on a CT scan, that it really does that it could take away, that intercurrent treatment could take away the randomness that we all also think is operational in terms of an ACS or some kind of other event which take place. So even though conceptually this sounds good, keep it in the back of your mind, we still have to prove it. And that's where we are right now. Here's a data, and I'm showing this for some of the fellows. This was one of my fellows who published this a few years ago, where we took a registry of patients, some of which everybody had a CT, some of which went on to have an acute coronary syndromes. And we looked just at plaque composition. And you can see across the range of Hounsfield units, which is generally how it's measured, from low attenuation plaque, or necrotic core as it's called here on the far left, all the way to 1K plaque, which is very, very dense calcified plaque. You can see the non-calcified plaque to the left is the volume of that is much more of a predictor of unstable plaque, or ACS. And as the plaque calcifies, you see that it becomes more protective. That's a pattern which has emerged over and over again in the literature, that plaque composition can be very helpful in us understanding the whole idea of the patient or the culprit lesion or the amount of plaque is at risk for acute coronary syndrome. And I was involved in this Emerald 2 study, but I think Bong Kwang-Ku did an amazing job on this. This is kind of a stepped up considerably using AI-based techniques. And what was interesting is he actually looked at around 351 patients that had definite ACS culprit lesions and had a prior CT. We contributed about 100 of these patients. And if you look, he aggregated a bunch of features from CT. Fractional flow reserve, which is an estimate from CT, average, again, estimated total myocardial blood flow, total plaque volume, a stenosis score, plaque burden, low attenuation plaque volume within the lesion, and any form of high-risk plaque like spotty calcification or positive remodeling. Aggregating these features, you can see he was then able to develop machine learning models to actually take a lesion and say, which one of these and what is the probability of lesion A versus lesion B actually going on to be the culprit lesion. And on the right-hand side, you see a lot of blue features. On the left-hand side, you see a lot of red features. Red features were additive in the model to predicting ACS, and blue features were negative. So you can see a much milder lesion on the right, and the probability of ACS was quite low. Even if you look at the very left, that probability of ACS was very, very low throughout the range of follow-up, whereas you can see a very prompt and increased and heightened risk, well over 80% in that lesion A. Ultimately, clinically, if you're referring a patient to CTA or whatever that test, these are the kinds of information that would be very, very helpful to us. And of course, this is the first time we've seen this presented this way, but I really believe this is, to me, it adds a lot to our understanding. There have been a lot of other kind of prognostic findings looking at that low attenuation plaque burden. In the Scott Hart, again, this is a limited sample size, a couple thousand patients. There were only some 45 MIs in here, but they showed about a twofold increase in myocardial infarction risk when that low attenuation plaque burden was greater than 4% of the total plaque burden. That's a good piece of information, that low attenuation, very, very low, or in sometimes called necrotic core. Again, another paper out of Dominique Day's group, looking at a large sample size, looking at total plaque volume, so showing a threshold of 238.5. Not sure we go down to the cubic millimeters in that minutia, but showed that a plaque volume of 238.5 was associated with a hazard ratio that's about 7-fold, which is really amazing. This is the first paper that showed a total plaque volume threshold. Trust me in that we still have a ton we need to do to understand the thresholds for what we considered high risk total plaque volume. But it is interesting to see that you can find a threshold for 7-fold for fatal and non-fatal MI. Here's some data again from the ischemia trial. These CT scans were old. It's probably the worst of what we're going to get. About a quarter of the segments could not be analyzed, but you again see a proportional relationship between total plaque volume and cardiovascular death MI. And what's important to this is, again, image quality was not necessarily the focus. 300 centers from around the world, but yet here we were still able to get an estimate of cardiovascular death or MI in a very, very large trial using total plaque volume. So lots of pieces of information are aggregated together and really give us some signs that the plaque that we can see on CT can be very helpful in guiding ACS risk. There's also about 80% of the heart is covered by fat, as all of you know, and it's in the immediate area surrounding the coronary arteries. There's fat, pericoronary fat. And if you remember your atherosclerosis 101, you remember that there are two hypotheses, either outside in or from the blood inward affecting the plaque, or outside in or inside out. In this case, this is the fat from the outside showing a cross-link, a potentially proposed cross-link between the fat outside as creating an inflammatory milieu, as you can see in the more red pictures on the left-hand side. The more red it is, the more inflamed the fat is, and is more at risk for acute MI or a culprit lesion. And the more yellow the fat is. And it's hypothesized that the fat has a shift when it is within a systemic inflammatory state. The fat becomes more watery or enters in a more aqueous state, and actually will facilitate these drops in the Hounsfield units, which we can capture. There have been several really good papers that have come out of the Oxford group. Now, whether or not you agree with the concept, it does fit along the lines of what we think as a mechanistic pathway for atherosclerosis. And the evidence is quite compelling. Several Lancet papers, including very recently, a very, very large Lancet paper in some 40,000 patients. So another piece of this, which I think could add very nicely to our understanding of what CT could offer. I think ultimately what you want to do is you see a patient, maybe 45-year-old patient, and you want to know how to track them, because I want to actually put them on preventive care. So we really want to move into a paradigm that we talk about serial changes. And again, here's just another paper from my brilliant Alex Van Roosendaal, where he compared patients with on statins to that and see what happened to their low attenuation of fibrofatty plaque. And we showed over time of about 3 years a reduction in non-calcified plaque on statins. This is from the paradigm study, but that would be the paradigm by which we are trying to understand. The challenge is, we've got to have a tool that is very, very sensitive to changes and is very accurate in a non-invasive CT. Is it accurate in relation to intravascular ultrasound or other types of invasive imaging? Here's just a recent paper that was published comparing a large sample of IVUS and CT. And you can see here on the top, the primary endpoint, the correlation between the two was 0.9. It was also 0.9 for calcified plaque. It was still high for non-calcified plaque. And if you go down on the left-hand side to the lower right scatter plot, you can see for low attenuation, it's not a great correlation coefficient of about 2.28. So if low attenuation or LAP plaque volume is really what we're searching for, right now we've got to be very concerned that we are seeing on CT what we are seeing on IVUS. But this is part of the process of developing evidence. Shouldn't be necessarily intimidated by that, but we should use that as a cautionary note when we look at studies. And it may explain some of the studies like we just saw, the recent Ekstrom trial, which didn't show positive changes in low attenuation plaque. But there are a lot of different analysis programs, quantitative software programs. They have quite a lot of variability on the range of stenosis, plaque volume changes, vessel length. The ability to read the different vessels is going to be directly related to total plaque volume, the amount of plaque that's non-calcified, et cetera. So right now we have to have a little bit step slowly into this and have a little bit of trepidation. I could give you a lot more information, but I think these two slides nicely illustrate the issue, as well as here. So I'm going to show you a couple of different. This is actually from the Oxford group. It's not a program that is available. I tried not to use one that was necessarily one that you would see, but you can see a serial scan. This is from patient that enrolled in one of our COVID studies. We showed marked progression here, particularly of non-calcified plaque. The patient increased very dramatically. And if you look at the lower part of the figures, you can actually see the changes in plaque over time. Not too much of a change in total plaque, but an increase, but a sizable increase in non-calcified plaque. And we can also look at changes in perivascular fat, which I think can be very helpful. In this case, we see this 2 scans of a patient that had if you don't know anything about the color codes, you can actually see on the right scan tons of more red as the patient's fat attenuation index score almost doubled, showing a much higher inflammatory milieu in the perivascular fat. So lots of ways we could do this. And of course, I think the questions that you're asking yourself, okay, there's a few studies out there, but really what I want to know is how do I select patients and who will have a treatment response? And this is actually absolutely where we are right now. And this is the developing evidence. So it's a call to action for all of us to think about how we can actually develop some of this evidence. A few trials that are out there, Evaporate and the Hearts trial, very similar results to look at omega-3 fatty acid treatment. The Evaporate trial used Vasipa. About 68 patients, even though they enrolled patients had a 20% stenosis. They were already on statins, elevated triglycerides and LDL greater than 40 to less than or equal to 115. They're randomized to Vasipa, 4 grams a day versus placebo. Their primary endpoint was at 9 months, and here they report the data out through 18 months. They did not meet their primary endpoint, but at 18 months, they did show a reduction in low attenuation plaque volume. And again, it was not their primary endpoint. The Hearts trial also showed that they were able to show a reduction in total plaque volume. They used a threshold of 2%, which is, I think, kind of small. When you want to look at threshold changes, a key factor in whatever measure it is, you want the measure to be beyond repeatability. That's kind of a key approach to this. And they did show that the patients that actually had a regression on plaque actually had a reduction in major adverse cardiac events. So 2 kind of intriguing trials, smaller trials, looking at intercurrent omega-3 fatty acid treatments. As you can see, a reduction in non-calcified plaque. And of course, then there's an observational study in patients with FH, no clinical atherosclerotic cardiovascular disease, 78 weeks of PCSK9 and high intensity statins, again showed a very, very small but significant decrease in total plaque burden. Again, we really need some better standards for what is a meaningful change. But these are, as a scientist, I look for patterns and I look for things that repeatedly show. And certainly I think all of these are headed in a decent direction and could benefit, obviously, from a lot more data. And of course, I think where the rubber meets the road for all of us is how well we implement these slides, this data into everyday clinical decision-making. And so, we've been focusing on a very, very large and trial, that registry that was funded by HeartFlow. We don't receive any funding for this. But it's something that we're using their product in this design registry. Design manuscript is going to be published. It's some 20,000 patients, and we're going to look at a variety of management approaches to see which ones are helpful to enhance implementation of therapies using plaque, because it is such a foreign tool, right? These measures are different for us. So how do we actually integrate that into clinical care and hopefully decide will give us some information? Just to let you know, we're pretty close to being finished. We should be finishing in the next couple of months. So look forward to this this registry to be published in the near future. So, but I want to just emphasize with you that throughout my career, we've seen foundational changes. And I think some of the work that you all are doing on artificial intelligence is truly going to be foundational. And we have another possibility, and it doesn't necessarily have to be totally oriented towards CT, where we're going from our prior approaches to say, what's the risk score? What's the probability of they having coronary disease? What's the likelihood to actually developing precision-based care where we can characterize the amount of plaque, we can characterize the type of plaque, and we hopefully can come up with more personalized approaches to care, somewhat similar to what cancer therapy is doing. And I really do believe that it's foundational because it's really integrating care within prevention, which is really a lot of why a lot of us went into cardiovascular disease. And it's not just, prevention of the patient once they have plaque, but if you think about it, it's really in utero. It's the family history. It's the mother who also had early onset hypertension, as did her mother and her grandmother before her. It's understanding the role of pregnancy. It's moving on to childhood. It's understanding how we can make meaningful differences so that we can stop the development. I'm not convinced as much that we can stop the development, but I certainly think that we can certainly delay the disease process quite substantially by engaging in better healthy habits, weight control that begins with our kids and adolescents. And as we move into young life and adult life, we can start to be more aggressive and maintain that history. I know when I used to live in Georgia, they destroyed your medical records every 10 years. Just think about that loss of information about what happened to a young man or a young woman when he or she was 12. And so we really need to retain that. We need to start thinking across the lifespan of how we can care for patients. And I think if you really let that ruminate a lot in your mind, I think you could see ways that you can make meaningful differences. And some people like to say when they think about the lifespan, if we think about prevention, that ACS is a failure of prevention. We have to, and although I like the mindset of thinking about it that way, I'm not sure that I totally agree with that. I think there's a randomness that we can't really quantify, but certainly thinking of delaying the onset of significant atherosclerosis is something I think is achievable today in a lot of different ways. So the Lancet Commission focused in on shifting our approach from ischemia to early detection of atherosclerosis, early detection, and I'm not sure about elimination of risk factors, but certainly better risk factor control, early identification of disease as we know it, stop calling it subclinical, and then we don't have to worry about it, but really focusing on screening and implementation of people that have atherosclerosis. We need transformative discovery science. There is no doubt about this. We're not ready for prime time, but I think we have to start thinking about this. It takes decades to be transformative in healthcare. It's going to take us a good bit of time to really be able to understand and feel confident that as we operationalize this, we are truly not only making it a place where some of our patients can get high quality care, but we can create a pathway of equitable access for everyone and not make it totally high cost care. So I think that it would be awesome if we could predict this. This is from the Lancet Commission, that if we really hit our targets, we could get our 82% reduction in atherosclerotic coronary disease deaths by 2050. That's a very, very daunting number, 80% reduction. But certainly I think we can take many steps forward in order for us to really shift our thoughts and ideas about not waiting for somebody to present to the ED, but really intervening much earlier and being intensive much earlier for all of our patients. So I will tell you, as somebody who's been involved in guidelines, it takes a while to let us create transformation, but it's all a part of how we can actually take where we are today and move forward. I think imaging is a prime opportunity because it really, particularly with AI-based quantification, it allows us more precision than we've seen in the past, perhaps a consistency in measurement. Again, lots of research is needed, and that's where I'm hoping I can inspire all of you to embark on many, many research projects for us to really transform our healthcare system. The impending look doesn't look so good, But certainly if we can get a very aggressive approach to this, I think we can do a better job than we're doing now. I'm happy to answer any number of questions, and we can have a great chat, hopefully in the next few minutes.
Thank you very much, Leslie. It was a great talk. I enjoyed listening to you. I'll start with a couple of questions, then I'll open it up. So if anyone has a question, they can just unmute themselves and ask a question. So first is, have you seen any differences in plaque progression?
What was the first part? I got a little
Have you seen any gender differences in plaque progression?
You know, I haven't seen a good study. I keep trying to, and the other thing I keep trying to identify is plaque erosion versus plaque rupture. So that would be a nice one, but nobody's really enrolled enough of N STEMIs in that, so where you'd get more plaque erosion. You know, what would I guess? You know, people have shown less coronary disease. That's not a surprise to us, though. You knew that 30 years ago, right? I think that there's some evidence that women don't calcify to the same extent as men. And that would be interesting. And certainly the degree to which they, and women actually generally, my CRP, C-reactive protein was higher after age 12 than yours. So we live more in an inflammatory milieu, which would make sense, and we have higher percent body fat. So the non-calcified plaque is very consistent with our higher percent body fat. The progression, because of the smaller amounts of plaque, is less, as you can imagine. But certainly that the inflammatory, the mechanistic pathway of inflammation, more fat-induced plaque would be one that we would expect. That they would induce more non-calcified plaque progression, and perhaps, you know, and that is good, you know, because if we think about treatment, maybe something like a colchicine, which is not a really expensive drug, maybe something that we would consider utilizing in a female population, or some other types of drugs. But certainly you would expect more non-calcified, you know, but I would love to design a trial where we would have everybody who's postmenopausal, and they've increased their Lp(a). We know women increase their Lp(a)s during menopause. So we've captured all of that. They have plaque, and I'd love to watch them progress over like 5 or 10 years. That would be, I think, the ultimate. And I think we would find out, particularly, you know, in diabetic women, we know they're at higher risk of cardiovascular death or mortality. Obese women at higher risk of kidney failure and all kinds of cardiovascular conditions. You know, I think we'd find some interesting results.
So do you think that's like MAGA was replaced by SPECT, right? Do you think atheroma imaging, you know, with advances in CT like FFR, plaque quantification, perivascular fat, and photon counting, and also with PET now tracer being available, which is for which you do not need a cyclotron or a generator. Do you think SPECT would be replaced?
You know, I will tell you that there are several health systems in New York that are replacing all their SPECT cameras. So I think that you know, the reimbursement for CT is helpful. PET, I think, is quite a good reimbursement. I think the future is CT, MR, advanced echocardiography, and PET. I do think SPECT is, you know, the challenge is it's been a workhorse, and a lot of the equipment is really old. And so it needs to be replaced with equipment like PET scanner that, I mean, 3 millisieverts of radiation versus 12. I will tell you, though, that CT scanners, particularly photon counting, if you, those of you who know anybody who uses that ultra high resolution mode, that's associated with a lot of radiation. So we're going to have to keep an eye on CT to keep it down. We haven't heard about radiation a lot, but it should still be a concern of ours to be careful with it in our patients.
Right. Does anyone else has any questions?
Hi, this is Claudia Gudea from NBI. Excellent talk. Thank you so much. I have a question related to perivascular fat index. Any studies in ANOCA and INOCA, the microvascular disease with angina and ischemia?
There isn't, but there's a ton of people that, sorry, fire alarm was going off here. They're just testing it because it's after 6 here. So we're going to ignore it. But yeah, there are a number of people that are looking at that right now. One can easily say that it's important. You know, we have a project with a CT surgeon who, where he's gonna debulk the fat surrounding the artery. I do think in men overweight and women would be more inclined to have more percent body fat, that even just the weight of the perivascular fat on the coronary arteries has to play a role. The amount of fat that you have has to play a role. And certainly, I think if it is an inflammatory milieu and it does impair endothelial function, there's no reason why it would not impair the microvasculature as well as the epicardial coronary arteries. It makes sense, right? So, you know, and I think people have implicated that as well into SCAD. So that as well, there is another, you know, idea that this inflammatory pathway can, and the amount of fat that the patient has can be impacted by, can impact the vasculature. It makes a whole lot of sense. We need more data though.
Claudia, you are muted. So.
I said probably we need more data. What kind of the inflammatory markers we have to trigger for therapy?
Yeah, I mean, I think there's a ton, and every one of the IL-6, IL-12, IL-18, whatever, you know, O-link panels, you can get an inflammatory panel and get, you know, 50 or so. Prices have come down. You know, I think there are also other conditions which are highly inflammatory, you know, autoimmune conditions, HIV infection, endometriosis, dysmenorrhea, which are all implicated as highly inflammatory, that we could find out much more about this inflammatory milieu and how it impacts atherosclerosis. Right now, I think the criticism with using the perivascular fat is you're looking at small changes in Hounsfield units, right? And so it's like, is that really a meaningful change? And so, you know, I think that we have to move beyond, you know, just looking at the radiomics of it all and seeing if we can actually meaningfully change, and it actually shows an improvement in outcomes. I think that's those are important questions as well as what you just proposed.
Thank you.
Thank you.
So does anyone has a question? Last one question. Thank you so much, Leslie. It was great lecture, and